Welcome everyone. We're just going to have a little run through of a pictorial, not a lecture, just a pictorial run through of what was accomplished, the lessons that were learned, and the improvements that maybe they can be made on our disaster medical assistance team that we sent from this hospital in liaison with Mercy Relief, which is a non-governmental organization, to a really terrible situation in the Philippines the end of last year. So if you want to ask questions, just raise your hands. It's no problem. I'll stop in between. There are only 3 slides with words in them, and this is one of them. The rest of them are all basically pictures. So the first week of November, a small depression or a low pressure area formed basically in the western aspects of what is called the Federated States of Micronesia. And within the next week or so, this became a tropical depression into a tropical storm and was upgraded by the Joint Weather Commission into a Category 5 cyclone, hurricane, or what we call a typhoon. They're all interchangeable. This was named Haiyan, and in the Philippines context, because it changed regions, they named it Yolanda. And what happened was this eventuated into the single largest storm in the history of mankind. It is the most, let's just say, when it made landfall, it was classified as a super typhoon, meaning winds in excess of 150 miles per hour. That means exceeding 250 kilometer per hour winds. When it hit the Philippines, the landfall was around 7th or the 8th, just crossing into the 8th of November. And it had displaced millions of people, and there were countless lives lost at that time because they just didn't have the capability to count the amount of people who had been lost. Within 2 or 3 weeks, there were 150 international medical teams situated on the eastern Visayas. Just to clear up your geography, because it is a bit confusing, this is the storm track of Haiyan, and it came from the Micronesian areas, developed, gradually hit landfall in the area of the eastern Visayas here, and then in the western Visayas, moving along all the way across into the Asian continent. What happens is that when you hit landfall over here, because of the geography of the place, most of the area was flattened. Most people, as most people do in many places, live on the coast, not the inland of an island or a continent, and they're vastly affected in various ways. Blowing up this map, it just shows you the picture of what the Philippines, the central area, looks like. So this is the eastern Visayas region. Tacloban City is what you've all heard of in the papers and in the news, was the worst hit, and most of the international teams were sort of situated around this area. Now what is sometimes ignored are the other areas that are affected by landfall, because people assume that the hardest hit areas are the ones, and there's also a point to that, the hardest hit areas are the ones where it first hits landfall, but the storm doesn't stop. And you can see that it tracked through all the way across the entire Philippines and hit landfall somewhere in Asia as well, without actually slowing down in terms of wind speed. So there are areas which were not serviced by many medical teams. Most of the medical teams, international services and NGOs, including the major organizations like MSF and ICRC and international hospital reliefs, were situated around here because that's where the most people or casualties were. So we decided, or not we decided, but Mercy Relief had decided as an NGO, because they had operations ongoing in the Western Visayas area, to schedule a medical team to enter in that region, and we supported them with the medical staff for that. They had the logistics, we had the medical staff for it. Blowing up that area, or this portion of this map, we have the province. Once again, this is the track of the cyclone or the typhoon. This is the region of Iloilo. And the city was mainly centered around the bay, and it was flattened as usual. This was an estancia region, which we primarily concentrated our efforts on, because the city was catered quite well, but as you can imagine, places outside the city or non-urban areas or rural areas are the ones which don't get the services that cities get. Because when you are an assistance team, or whether you're local or international, the first place you land is the airport in the major city, and you concentrate your services there. But as expected, most of the problems occur on the outer rim, where there aren't any medical services. So Estancia was the northern region of the Iloilo Island. This island is called Panay, and we concentrated our medical teams or our mobile clinics in that region. This is not an unknown area, by the way. Batad province is a UNESCO World Heritage Site for its fantastic scenery and its terrace farming, so it's not something that is unknown whatsoever. In Estancia there's also a port, and in that port there were reports of an overturned tanker which was leaking bunker fuel into the beach. And when you leach bunker fuel, it's a little bit different from a gas leak, or a little bit different from refined oil. This is almost crude oil, which is given for ships, and it's fuel for ships, and has lots of benzenes and toxins which, once dissipated into the air and the surrounding area, are going to cause respiratory problems. So Mercy Relief identified that these were the issues that need to be dealt with. There wasn't that much of very good primary health care in the region anyway, so people who are affected or vulnerable populations like the sick, the elderly, and the children are the ones that we were targeting our services for. This is the picture of basically the bunker fuel leak which came onto the beach in the town of Estancia. It's not from that, but the ship that came across over there, and that ship had sunk. And this oil spill, or crude or bunker oil spill, had gone on for miles and miles onwards, thus releasing lots of toxins. And this is about 1 month post, maybe more than a month post, and it still had not been cleared. So it's releasing toxins still into the surrounding villages. And they can't do anything about it. They don't have the resources, they don't have the manpower, they don't have the technique or the chemicals to remove such stuff. So it belies onto the international population, or international services, I'm sorry, to come and clear what's been going on here. And you can see it's a legal minefield as well, right? Who was the company involved? What are they doing about it? Why are they not here? This picture should show you the force of what a Category 5 typhoon does. What you will notice, and there's no wind here, this is 1 month after, is that everything is facing that way. If you look at all the trees, and these are strong trees, where do all the leaves point? In one direction only. This is 1 month after the effect. Yeah, and basically what you see in a windswept area, and this is what you mean by windswept in the extreme version, everything has been blown that way. It's lovely scenery otherwise, but you can see the effects of a strong wind. The situation for the town's inhabitants was not that great either. When you have a displaced population from your beachfront and your villages that crop around the bay area, you have to move inland. Otherwise, you're not only exposed to more harsh elements again and again because you don't have shelter, but there's also a fear that more typhoons will come. You don't know. You don't have access to satellite images. You don't have access to internet. So you are only going to fear more typhoons coming. So you move inland. This is a tent city provided by Médecins Sans Frontières, which is MSF, or Doctors Without Borders. And they have a very well-stocked and a very efficient logistics unit. They're a big organization which builds up tent cities to house people in good sanitary conditions until they're able to re-establish their own homes. This is the team that was sent out by Changi General Hospital in concert with Mercy Relief. So who we have here is the Mercy Relief logistics man. He's Thomas Ho, who is a paramedic who used to come into our ED all the time. He knows us well, and he's the man who handles all the logistics of Mercy Relief. These two are cardiologists. Yes, they are. Marjorie is a trainee cardiologist who actually is from Iloilo region, so she knows the area and the dialect very well. Sarah Teo, you know, who works with us. Over there are 3 nurses. From the top is Sherhan, who's an orthopedic nurse. Then comes Amina, who is a psych nurse. And this lady over here is Arlene, who is a nurse manager and has lots of surgical experience in the past. I don't know who that guy is, but apparently he just joined us halfway, and he turned out to be a pretty decent doctor in the end. And that's Brian, of course. This is the other slide with only words in it, and it's not much more. So when it comes to a strategic point of view, there are certain things that you want to accomplish when you have a mission like this.
Somebody's passport was... something happened and they couldn't go, right?
Sure, but that's not the point of this talk. So when it comes to an actual, let's just say, on-the-scene management of when you arrive to let's say, a mission or a humanitarian effort or a disaster site in general, there are certain things that you need to take into account if you are the person who's responsible for your people and your team. To avoid any unnecessary troubles or international problems, and for the safety of your team, you have to take these things into account. And just from an experience point of view and from looking at all the literature around the world and all the experiences of the many disasters that people have faced, the one thing that really goes first and really doesn't work is communications. That's the first thing to go. But we were a month into our mission, and re-establishment of communications, internet access, satellite access was all done prior to that. So we had actually no problems with communication, which is a relief. There are other things that need to be focused on when you are functioning as a sort of a mission head or mission lead, and these things do come into play no matter how distasteful they are, and we'll come to that a little bit, maybe a slide or two later. This is where we sort of stayed. We didn't stay in the tents, but we're staying in a block of apartments or a motel just behind. It wasn't a fancy motel, but I suppose for that region it was a fancy motel. There were 5 of us in a room, and there were 2 rooms. We were joined also by another Filipino doctor from the Manila area, apart from Brian, and she stayed with us as well. So there was basically 10 people on our team itself. This was the MSF facility as well, right in front of us. These are the tents you can see at the bottom, which they wrap up and they open up. They look like this. So there are thousands of these tents to house and give out to house the displaced population. Once again, if you look at the scenery behind, it's a windswept area. That was their bus terminus, which you can see is partially destroyed. And that's what the area looked like. So there's not a very mountainous region. It's very, very flat. And that's why landfall or windswept areas are very, very problematic for them. We were not alone. We could not go there by ourselves and just start something. That's not possible. What we have is coordination with the local NGOs, the local non-government organizations. Because just like every other, let's just say, moderately developed country, that their government cannot, by no fault of their own or sometimes fault of their own, cannot provide for everything everywhere within a couple of weeks or so. So they're heavily dependent on local non-government organizations to help them. So in concert with these Help Panay and disaster relief or disaster response centers in that region, Mercy Relief, who has good penetration into and good liaisons with these organizations, was able to get together a package or a schedule for us to do. So we just ended up augmenting their schedule. What we did was, they were going around anyway in mobile clinics, we augmented them. Because what they lacked was medical expertise, and we provided that medical expertise. They had the drugs, they had the pharmacists, they had the help and the logistics, but they needed medical expertise, and that's where we came in. So it was a very, very good symbiotic relationship, and we were very thankful that this was all in place. If this was not all in place, you can imagine going there and setting up and finding and sourcing drugs and people to drive us around would be a nightmare. So all this was made very easy by Mercy Relief and made very easy by these organizations over there. These organizations are there for a long time. Their work is ongoing. It doesn't stop. They get hit by typhoons often, and they're on Facebook. If you want to go support them, please do so. Yeah, they do fantastic work. So that's what the scene looked like, and there were points in time where even I was worried maybe there might be another typhoon coming, but that was not the case. This is one of the Bay areas. This is a village called Embarcadero, and it was, as you can see, near the shore. The oil spill was not nearby, but you could smell it from there. You could still smell it from there, even miles and miles away. This sort of surge or the stormish looking atmosphere they're looking at sort of cleared up very, very well. But the scene was set up by, once again, the local organizations and the villages and their barangay captains. A barangay is a village over there, and everyone has a head, and the village head or the elders would set up with their stronger and fit men to build shelters for us to have a look at their patients. And patients, I mean the entire village almost. So what it looked like was this. Basically tents put up, signage, proper triage, and that doesn't happen by itself. It happens because you have to have a little bit of command and control involved. When you get hordes and hordes of masses of people, and let's say about 200 or 300 people coming at you at once, you have to have a system. Doesn't matter what system you have, but you have to have a system so that you can organize, treat, communicate, dispense, and move on from there. And I could not have done that without help. And the help that came along was by a group which has already been there and embedded for about 3 or 4 days, and they were a bunch of American nurses. And they're not young nurses. These guys are experienced. They've been to situations like this before, like Haiti. They're experienced pediatric nurses like this lady over here who's giving directions. You know exactly who is in charge and what they're doing in this picture, because that's exactly what you need. So they were there, and they're called RNRN, which is the Registered Nurses Response Network in the States, and they send volunteers out to all sorts of areas for help. So these guys and these girls had been there for about 4 or 5 days before us, and they're doing other regions, and they were glad to join. So when they first came, I identified myself, they identified themselves, we organized triage, and well, they organized triage quickly, efficiently, and triaged 200 to 300 patients within 3 or 4 hours by themselves, obviously with a couple of our nurses tagging in as well. So we could not have done anything, or we would have been bogged down or mired down in hundreds and hundreds of patients with a systemic problem of actually having to triage them and treat them without their help. But you can see that command and control is very important when you've got areas and throngs of people coming towards you. Even though we had structures, and this is one of those other beachside villages, structures that were destroyed in the foreground, or in the background, I'm sorry. And in the foreground we have people coming to the only stationary structure left, basically. And they were coming there just to be seen. And they come there to be seen not because they have a certain ailment, but they're worried about something. And the vast majority of the time, they're only worried about their children. If you had been hit by something in 1 month of no actual medical care, on a background of basically no primary health care or very little primary health care, there's basically only one thing you worry about, and that's your children. So could you say they were worried well? Of course they were worried well. But did they deserve to be seen? Of course they deserve to be seen. And every child over there had something that was not perfectly right with them. The vast majority were okay, but every child had to be treated and triaged in the normal way that we do. Were there problems which we could not see? Yes, there were, and I'll get into that in a short while. Because people came in all sorts of manners, and we entered this disaster about a month later, so the people who were really, really ill and injured had died by then. And we saw the survivors, and the survivors are generally of hardier stock, and that's just a fact of life. When they came to us, sometimes they had to go for miles and miles. This lady had moved for 5 or 6 miles on a stick by her own, and obviously when she comes to us, she's tachycardic and hypertensive and sweating. So there are things that you have to take into account of where they come from before you decide that this is angina, which it isn't. When they were happy that we treated patients properly, they would go back and they would bring their children to us because they trusted us then, and they trusted us to treat their children. And when you have triage, you really, really cannot mix the triage together. So what these nurses figured out in their experience is that you have children on one side and adults on the other side. And then you triangulate your focus on depending on what size of the queue really, really is. Sarah joined them, learned a lot, and in the end she was able to demonstrate her own triage prowess in a couple of days. So that's what a scene of our pharmacy looks like. Every day we move from a different village to a different village. We spent 5 days and treated about 1,800 to about 2,000 patients in those 5 days. This is what a pharmacy looks like when it's just built out of nothing. So everything came in boxes. You have to open up, stock, check, dispense, stock check, repack, and then send it back home again to wherever your stock is. These were nurses who had not done that before, or done that very, very long time ago. And yet they were able to perform their duties without any problems. No flinching. This is what the building looked like on our first day when we arrived there. We had to move into a very small post office-like area where there were just a couple of rooms. And translation was not a problem because they had provided translators. That's how good their logistics and planning was. They had provided translators knowing for a fact that only about 2 or 3 of our team spoke Tagalog or the local dialect. But then again, most of the patients that we saw actually were quite conversant in English, so we didn't have a major problem. Sometimes we had to ask our friends for advice. We didn't know what a certain word meant. And that was easily done because you're basically 2 to 3 feet away. Sometimes you don't know what mebendazole is or how to treat different fungal or maybe even helminthic infections. And you have to learn on the spot. Sometimes the doses are different of amoxicillin and you have to learn on the spot what it is. So basics were accomplished then. On top of that, every patient needs to have a record. No matter where you are in the world or what you are doing, every patient needs to have a record. So this is the kind of record that we had. And these were stored. And so was the prescriptions, because you can't just dispense medication just like that. Doesn't matter where in the world you are, you just can't dole out your medication. So there has to be a prescription and a record as well. And this is what it looked like. So they are prepared. Yeah. So we weren't going in to give them a miraculous system or anything. No, we were there to augment. They are well prepared for anything like that. Well prepared. I would say better than us. And that's a demonstration of how, even though that's not your normal job, and you don't know what to do or how to do it, you can adapt. These are nurses who work on the wards, and they don't sit down and dispense and stock check and take care of medications every day. They do a bit, but not to the scale like this. And what they did, without flinching at any point in time or ever complaining, was work hours and hours on end in a small sweaty area and dispensing medications and including a translation to people who didn't realize sometimes what they were getting. And did this basically without almost with a 0 error rate. Sometimes we were overwhelmed with patients and we could not see more than, let's say, 50 or 60 per hour by ourselves. So I co-opted the people who I trusted, and I trusted everybody in my team. And there you go, Sarah and Arlene, who are seeing patients. They're basically seeing patients. They clear it with us, they do the exam, they take the history, the vitals are already there, and they just, she speaks the local dialect, so she was good enough. Sarah documented, wrote up a plan, wrote a prescription, and I signed it after having viewed the patient myself with their history and exam. So it doesn't have to be a doctor, it doesn't have to be a specialist. In fact, it doesn't need them. Specialists, in fact, not really wanted if you're a super subspecialist when it comes to treating primary health in these situations. You're probably wondering what I was doing at that time. Well, there were sort of interpretations that I need to do. I need to maintain good relations with the locals. I need to explain what we were doing and sometimes improve on certain situations. There are other times where I was really involved in international relations as well, in providing good care and holistic care to my team. And there's one thing that I learned very, very importantly, and that you should all remember, is that you should never, ever challenge Filipinos to basketball. That's their national sport, and they're really, really good at it. And even the Americans were going, OMG, these guys are great. And they are really, really good. And they're quite serious about it, so never do that. Never do that. This is the only other slide with the last slide with words in it. So you can see that there's a cycle to almost every disaster. Yeah, and this is a very basic slide which every disaster course has and every disaster book has. And we entered this cycle at around this point. Okay? So just a little bit after the response and well into their recovery. Now the recovery is going to take years, and the recovery is not just a physical or a structural recovery. It's a little bit more than that. What we saw in terms of medicine, as you can imagine, is not acute response. So we weren't there as an urban search and rescue team. We were not there for major trauma, but we were there for the results and the sequelae and the 2 or 3 week later of major trauma. And when I say major trauma, I don't just mean the cuts on your legs. But speaking of cuts on your legs, this is what we had. This is a case whereby we had to improve, adapt, and then improve and adapt again the next day. So there were kids who are generally undernourished because they're living in an undernourished area in the world. On top of that, they've been exposed to elements which you are not generally exposed to. On top of that, they've had cuts which are not treated. You don't actually have a high vitamin content in your blood, and so you get infections. So infections were the things that we saw the most, especially in children who are walking around bare feet and knocking into things. This poor guy had an abscess on his forehead the size of a golf ball. He wasn't very unwell. He was pretty well taken care of so far by his local services, but he had an abscess. And then it comes to mind, how exactly do you treat this guy? You don't have drugs, we don't have ketamine, we don't have sedation. And with communication errors in the first day or two, we didn't have any scalpels, we didn't have local anesthetic. So what exactly do you do? Well, what you do is you adapt to the situation. How do we treat him in terms of pain? We had antihistamines, we had NSAIDs, we had all sorts of paracetamol concoctions, so we gave the cocktail of the lot. What's the best way in terms of treating pain for a child? I'll show you a little bit later as well. But this is one of those situations, unfortunately, where I had to treat or distract his pain by causing pain somewhere else. He also had dramatic looking abscesses and infections in his foot. So how to distract him and keep him concentrated on something else while we're cutting into his head with a shaving blade, which we had, I'm afraid to say. But it was clean. It was a sterile shaving blade, but it was a shaving blade, as you can see over there. We had to do it in the first day because we had nothing else. And we had to distract him by causing a little bit more pain. And yes, I will never forgive myself for this, but I had to cause pain to solve some pain. And what struck the nurse, and I didn't even notice because I was too, let's just say, adrenalized at that point doing whatever I was doing, was that this kid had no tears. And you can think about that for a while. This kid was crying so much, but he had no tears. Which shows you about the nutrition state of some of these kids that we saw. Sometimes we ran out of light. And this picture was into the evening of that day. And we got cases of sometimes just accidental trauma on that day itself. So a finger had been lost or almost lost or partially amputated, and we had to do something about it, otherwise he'd just lose his finger. And there was no light except for a part of the church next to our building. That's the only area we had light coming out in from a window above. And you can see from this area that it was a very holy place where we operated on, which was good to a point, because many things happen in this photo. So as you can see, there's plenty of people distracting the child. You can see modern technology in the form of distraction in terms of an iPhone. We had loaded him up with lots and lots of analgesia beforehand, and as well as an antihistamine. I think we had a little bit of local anesthetic at that point. But sometimes God has a little bit of a sense of humor as well, even though you're in his house. The only suture that we had at that day, on that day, was a disposable suture. And when we opened up the disposable suture, it has been disposed of, as in it had melted and it had gone away. So all we had left was a little needle, which was not great after all the preparation that was done. But he needed a debridement, he needs stitching. So what we ended up doing is, because the parents couldn't afford it, we took a collection and we sent this guy to a nearby hospital. So this ended quite well. We learned from that, and we sort of said never again. We're not doing anything like this ad hoc anymore. So we once again got our logistics in play, and before the beginning of the next day we got hold of surgical equipment. I had brought lots of sterile boxes, thanks to Tialing over here, lots of sterile boxes and surgical sets myself, so we had this and we made a makeshift scalpel that way, but we didn't have the drugs. So we got some lignocaine, we got a little bit more drugs wise, we got some bandages, we got some stitches, and we were prepared for the next day. And that was a thankful, because we got lots more procedures as the days went along. This is where a really good, experienced pediatric nurse comes into play, because not many people can do this, yeah? And you need a really experienced nurse to tell you when things are wrong, and to hold down children the proper way, and to keep everybody calm when you're doing a procedure. We finally had some lignocaine, and this is an abscess which was drained at the back. You can see all sorts of implements in the modern setting, once again, lights using by torches and phones and recordings going on. And what happens when we let them go? Well, just like here, you need good follow-up. Good follow-up means proper explanation of antibiotics, when to give them, when to get reviewed, and what happens when things go wrong with your child. What's the best analgesia for children when they're undergoing procedures before and after? There's only two things that I really know of in my training, and that's sucrose with a little bit of suction to it, to your palate, and it's a very good analgesic. I'm not kidding. So sucrose is a good analgesic. Sugar. And the other thing, as you probably all know growing up, is that safely snugged in your mother's arms is very good analgesia. So that's what we tried to do as often as we could. Soon became very, very good, all of us, even Amina here, who doesn't deal with wounds every day. she became really good in identifying what needs to be debrided in our own local little small theater that we had. So everybody improved as the days went along. That's the improvement to the point where we became the pediatric nurses. So we could hold, we could sort of debride, we could sedate, we could give our own analgesia, we knew when to give a lollipop, we knew when to take the lollipop away, and we knew how to basically debride and clean up the wounds without major psychological harm being done to our children. But the children don't only have psychological impact from what we do. There is a tremendous amount of water under the bridge which you don't see. And this was Mercy Relief doing what it does best. Thinking of the stuff that medical people sometimes don't think of. These are kids who are sitting outside our dispensary or our clinic where we were. And what Mary, she's a Mercy Relief worker, what she was doing is engaging children to not just distract them from what was going on inside, because sometimes you had crying children inside and worried parents. She was entertaining them not just for the duration of that period, but she was also gleaning the impact of what had happened. Because when you ask children to draw, it kind of releases what their inner thoughts are sometimes. Well, a lot of times. And what you see in this picture is what their thoughts were. And it's not nice thoughts. These are thoughts basically of water taking their houses away and winds destroying their villages and trees, as you can see here. And that's what kids of 4 and 5 years are drawing. So you can imagine what they're actually thinking and what their thoughts are, because it's all pictorial. So what Mercy Relief and other organizations do is far more important than what we did. And that's psychological debriefing, psychological therapy. These are a bunch of kids, while we were seeing the adults and doing other things and medical stuff in the surrounding areas, they brought their kids here and they told them stories, good stories, funny stories, engaged them, brought them back to something that was normal. Because kids need to be brought back to something that is normal for them. They've had a traumatic experience, the last thing you want is giving them more stuff. So bringing them back to some sort of normalcy is very important. That's one of their local priests. He's quite a cool priest, as you can see in later pictures. And that's what they're doing. Using what they know best in terms of humor, dialogue, song, bring the kids back to what is important, being kids. Sometimes it's the adults that needed some psychological treatment as well. My regret is that we couldn't take a Filipino psych nurse, which we have over here, because that would have been essential, really essential to what we were doing. Because most of the scars that were left by Haiyan were not really purely physical. We saw lots of psychosomatic complaints, and most of the time they were worried that, will it come back? And most of their physical complaints were manifested in that way. Luckily, one of the American nurses that we had was a psych nurse, and she was also part Filipino. So she was able to organize, with our help and with the local area, to organize a separate room on 2 or 3 of our occasions that we went up to the clinics. 2 or 3 of our clinics, a separate room where people were invited to come and debrief and tell their stories in Filipino as a psychological debrief, to figure out that this did happen and to deal with it in their way. But you have to talk about it to deal it in their way. And sometimes in Asian cultures it's very difficult to talk about it. But she knew that, because she's well trained. So we were lucky to have her as well. All this is obviously hard work. He's not crying, he's just a little bit hot from a hard day's work. And if you go out at 5 o'clock over here, you'll see him doing this as well. But it wasn't easy. And I credit my team for that. That's what we got. That's the kind of rations that we got every day. It is basic, but it is better than most of the local villages. It's got our carbohydrates, it's got our protein. What more can you ask for? So it wasn't that easy, but you needed a little bit of rest and recreation at all times. And when I say all times, you gotta joke while you're in there, you gotta joke while you're out there, otherwise you lose yourself in the problems of the moment, because there are plenty of problems over there. So this was organized at the end of our 5-day stint by the village elders or the village chief, and a few people had a really, really good time. R&R and debrief is important in all aspects. If you don't debrief your immediate friends, relatives, co-workers, you're going to have deep psychological problems after that as well. So every day we sat around and we talked about what happened. And you will be surprised to note there was not just laughter and a little bit of learning, but there was lots of tears by our co-workers as well. I'm not going to say who, but there are lots of tears as well. But that's the downside sometimes, that you have tears. There's always a good side to things as well. And what we thought was a very good way to de-stress and involve the local population was, after our clinics, we invited them to have some sort of a game. This was a beachside village that we went to. Lovely area, as you can tell. And we de-stressed in our own way, because you need that. All the powerful things that you see, sport is probably one of the most powerful things that can de-stress a population. And yes, we gave them the ball after that. And they enjoyed that. And they will remember something, hopefully, that some people came and then got thrashed by their team, because they are really good at whatever they do. So it was important to de-stress. This was another one. That's the priest I was telling you about. And this is one of the other places where we had a clinic in a school. And once again, international match with all the good things that are associated with humanity. It's not always all about play. It's about work as well. So when you go to something like this, you have to have a record of what you did. And you can't just expect a computer to record everything. You can't. We don't have the luxury of that. So we had to physically and manually record all the patients that we saw. And it was a struggle deep into the night. Yeah? You can see the girls are pretty conscientious. The guys are pretty conscientious too, but it's just in a different way of conscientious stuff. So we do our work in a different way, as you can tell. But eventually, you are greater than the sum of your parts. As a team, you are definitely greater than the sum of your parts. Because when you get cardiologists willing to go out into the open without their echo machines and without their fancy toys, just like us, without our fancy toys and machines, and you see patients which are not used to, you see children, you see primary health, then you know that they have elevated themselves to something greater than themselves, that normally function in a general modern hospital. When you have nurses who are more than capable than some doctors perhaps at doing a good history, exam, and even the subtle psychological and cultural manifestations that come out when people tell you that they've got a stomach ache, but it isn't really a stomach ache, it's something more than that. Because there were other issues in a different culture that we did not expect. Their primary health care issues that we needed to surface to them. We needed to make some follow-up arrangements. We needed to glean that sometimes their headaches are not just a headache, but something more. Without going too much into the individual cases, nurses sometimes pick up more stuff than we do. And that's a credit to them. Super Typhoon Haiyan was the largest storm in history. And it basically left about 10 to 11 million people displaced. To this day, there are quite a few million people displaced. We lost 6,000 and above souls, and it broke a lot of bonds. But what it didn't do is break every bond. You can see a well-oiled machine here that's working in unison, who don't know each other prior to 2 days before meeting, but working in great harmony and efficiency to do what we had to do over there. The other thing that Haiyan did not do is to tell the Filipino public that everything was lost. Because this demonstrates, and everywhere we went, is that they proudly claim that we are still here. After the strongest surge in history, they are still there. What Haiyan also showed us is that we were welcome no matter where we went. And that we were never treated as outsiders, but as family wherever we went. Before, during, and even after our stay. Because eventually that's what it's about. What it's about is trying not to challenge Filipino kids to basketball, because you know there's a bad outcome to that. But what it's also about is teaching these kids, well, not teaching these kids, but experiencing a very positive event with these kids after a very negative event. Showing them that despite all of that, your neighbors still care about you. And sometime in the future, maybe, when they grow up, or their kids grow up, they will be stronger, they will be wiser, they will be far more well equipped to come and help us when we have problems. The red shirts that they're wearing is a quotation from a man who's far smarter and wiser than all of us, and is the last slide I'll leave you with. If you decide that humanitarianism or relief efforts or disaster medicine is something that you want to do in the future, you know where to find us. So be safe in your travels, and thank you for coming. Thanks.